I will be presenting this presentation with Ashna. Before we start, me and Ashna just wanted to give a huge thank you to Dr. Vedantham for mentoring us and kind of walking us through this. I think there's a lot of good educational pieces to learn from this paper that everybody can get something out of. So the paper we chose to do was called the PRESERVE trial. It was recently published. It stands for Predicting the Safety and Efficacy or Effectiveness of Inferior vena cava filters, outcomes at 12 months. So since this is a discussion about IVCs, we thought we would start out with an educational piece, kind of talking about PEs, DVTs, and IVCs before we get into the piece. And this is kind of geared towards our audience of med students and kind of what, educational pieces that are good to know. So we thought we would do this case-based so that we could keep it engaging for everybody. So we have here a 57-year-old female who came into the ED because of severe dyspnea, cough, and pleuritic chest pain for 20 minutes. 3 weeks ago, she underwent surgery for a total right knee replacement. She has no other past medical history. The patient appears distressed. Her pulse is 112, respirations are 24, and her blood pressure is 110/80, and her SpO2 is 85. She is a former smoker, and there's a mildly tender surgical scar on her right knee. So the first question I would like to open up to the audience, you guys could feel free to just unmute or send in the chat, is what is the most likely diagnosis here, and what would your differential diagnosis be?
PE.
Okay, awesome. So PE is definitely the leading differential, but it's always good to think about some other things that can, cause a similar picture. Does anybody have just a few differentials we can add for pulmonary embolism? Awesome. So I see a pericarditis. MI. Awesome. Awesome. So the big ones, kind of the big buckets, I like to think of pulmonary embolism differentials is you have, your pulmonary causes, some cardiac causes, and also some psychiatric causes. So some we thought that were most pertinent were like pneumothorax, pneumonia, COPD exacerbation, MI, aortic dissection, pericarditis, and anxiety. So that's basically that. And the next question for everybody is, so what are the most common etiologies of pulmonary embolism? Where do pulmonary embolisms typically come from? Awesome. So the leading cause is DVT. We also wanted to just point out some other causes, such as you could have air embolisms, you could have, fat embolisms, septic embolisms. So although DVT is the leading cause, and whenever we think of PE, we think of DVT, just know that there are also some other etiologies for pulmonary embolism as well. So given this kind of, history, we wanted to tie in a little bit of the Wells criteria, which, I think every med student should have at least a good idea about what its components are. So what pieces from the history do you think are good, would contribute to the Wells score? And just so that everybody knows, the Wells score is basically a score to help us figure out the pretest probability that somebody has a PE, whether it's likely or unlikely. So awesome. So I see here tachycardia, symptoms typical of PE, recent surgery, making her hypercoagulable. Great. So as you can see here, down on the bottom right are the clinical signs and symptoms of DVT, it's basically the Wells criteria. So it's kind of in three different buckets. You have the most weight, which is 3 points, and then 1.5s and the ones. So in her case, obviously PE was the most likely diagnosis. There were no, other alternate diagnoses that were more likely. So she would get, 3 points. She was tachycardic, as everybody pointed out. So that adds another 1.5 points. And she did have a recent surgery, which makes her hypercoagulable, adding another 1.5 points. So she fits under, so if you add that all together, it's a Wells score of 6, which would be greater than 4, which is kind of the cutoff for, PE likely versus PE unlikely. So essentially from the Wells score, we found out that she had a high pretest probability for pulmonary embolism. And this is important because it helps guide the management later on. So moving on, we wanted to just throw in the Virchow's triad here of basically things that can cause, venous thrombosis. So essentially, everybody learns that, there's 3 kind of components, which is stasis of blood, hypercoagulability, and endothelial injury. We also wanted to point out, inflammation. There's been a lot of recent studies that kind of showed that, inflammation can induce venous thromboembolism, even in the absence of, any, vessel disease or vessel wall damage. So things like, rheumatoid arthritis or like inflammatory bowel disease or like lupus are all different things that can kind of also contribute to forming a venous thrombosis. So getting into the management a little bit. So this is the algorithm from Up to Date, and we'll just go through it quickly. So whenever you have a suspicion that somebody might have a pulmonary embolism, the first question you want to ask is if they're hemodynamically stable or not. In this case, the patient was. And the next big question to ask was whether or not anticoagulation is contraindicated. If so, then the management is very different from if it's not indicated. So in this patient, there was no evidence that anticoagulation was contraindicated. So she would kind of fall under this scheme over here. So then the next question you ask is, you use the Wells scores to kind of figure out, is this a high suspicion for PE or low suspicion? And based on what we talked about before, she had a Wells score of 6, which would fit under the high suspicion. So in this case, you anticoagulate right away because you don't want to delay, treatment before you kind of do the workup. Whereas if it was a low suspicion, you kind of make the decision whether or not it's more important to anticoagulate them first or get the confirmation with diagnostic evaluation whether or not they have PE. So in this case, it was high. So we would give the anticoagulation first, and then we would work it up either with like a CT angio or a VQ scan. And then once PE is confirmed, then we could consider if we want to do any more invasive management, such as thrombolytic therapy or not. So now we wanted to kind of tie this into IVCs. So if she had a recent intracranial bleed, that obviously changes the whole algorithm. And that's where the IVCs come in. So here is a slide with a bunch of the different contraindications to anticoagulation. So the general principle here is that if the patient had any sort of evidence of a recent bleed or anything like that, it would be a contraindication for anticoagulation. So, for example, part intracranial hemorrhage, a recent stroke, things like this that can all put the patient at risk of, life-threatening bleeds, would be an contraindication to anticoagulation. Which then moves us to, IVCs and kind of, how they work and where they're placed. So here is an example of a filter that's placed inside of the inferior vena cava. As you can see, ideally we would want it infrarenally, before the two kidneys. And as you can see here, you have the kind of legs of the filter, and then you have the kind of hook on the top. And obviously, if there was a DVT down here, it would obviously, the principle is that it would stop that from actually entering the lungs. Over here is a X-ray of an IVC in place. You could see the kind of legs over here, and then up here you have that hook. And that hook is important because that's how we actually retrieve the filter. So here we just wanted to show, we thought it was a cool placement of an IVC. So as you can see here, this is obviously here. So right now what they're doing is they're under fluoroscopy. The first thing they do is they introduce the sheath, and then they perform the venogram here, and then you could see that it showed, this is the IVC over here. This is the sheath that's being introduced, and then you could see that it's lighting up both the renal veins. And again, we want to be under that, we want to place that sheath under the lowest renal vein. So that's the renal vein. And this is the diameter of the IVC. If the IVC is too big or too small, that's a contraindication for putting the actual filter in. So as you can see now, they're advancing the dilator. So that's going up there. Or I'm sorry, they're advancing the sheath. And then now they're advancing the filter. And then they retract that sheath. You can see it coming down over here. And then eventually the filter gets deployed. You can see there. So now the filter is fully deployed. And then they do a venogram again, just to ensure that the placement is proper. And in this case, it is. So that was kind of just, we thought it was a cool little add-in. So now this brings us into where the study kind of came about, and Ashna will kind of take over now and talk to us a little bit about the history of IVC filters and how this whole study came about.
Great, thank you, Austin. So now that we're all kind of experts on the indications for these IVC filters, how we place them, and so on, we're going to move on now to kind of talk about the studies out there on these filters. So first off, an IVC filter itself is a pretty complex piece of instrument if you think about it. It needs to be stable enough to reside within the IVC, but at the same time, it needs to not cause any damage to the vessel walls and also be resistant to the blood flow and the possibility of migrating, embolizing, or fracturing. So there's a lot of physics that goes into the creation of this filter. And so when it was initially released and it increased in prevalence, a lot of complications came about. And along with these complications, there were several lawsuits that came about as well. So around this time, the FDA, they actually released this national advisory where they asked the pharmaceutical companies to kind of take on the burden for releasing some post-marketing data and really addressing the fact that these filters were having presumably all these complications. So at the time, an interesting thing happened. So SIR and SVS, as independent bodies, formed this partnership with the pharmaceutical companies, such that they would run an independent IVC filter study, but it would be funded by industry and ultimately would be brokered by the FDA to ensure that it was done in a reliable and unbiased manner. So that's a little bit of the history for what really drove all these IVC filter studies to start emerging in recent times. Go to the next slide. And the study that we're going to focus on today is the PRESERVE trial. So predicting the safety and effectiveness of inferior vena cava filters. The study is still ongoing, but we're going to focus on their most recent outcomes, which is at 12 months. So the goals of this study is to look at vena cava filters, which I'll call VCFs from now on, with respect to both their safety as well as their effectiveness. So this study was a multi-center prospective, non-randomized type of trial, and it was done across 54 sites. They placed filters in 1,421 patients with the inclusion criteria that they be adults and have an indication for it, as well as be able to comply with the follow-up the study required. They also limited their VCFs to 7 major manufacturers. The exclusion criteria were pretty intuitive: people who had pregnancy-related contraindications to radiation or contrast sensitivity. And the range for the filter placement was October 2015 to March 2019. Patients were followed up at various time points. At baseline, 3 months, 6 months, 12, 18, and 24. Once the filter was removed, they were followed for 1 month after as well. And imaging was repeated at 3, 12, and 24 months. The primary statistics that the study conducted was an exact binomial test, which is to compare the proportions that they observed to the expected thresholds that they'd set. And finally, they also did a poolability analysis, which is what several studies do to ensure that when they combine data from, say, different brands, in this case, it's being done appropriately without any bias. All right, so how did the study define safety and effectiveness, right? So they defined effectiveness as no new clinically significant embolisms at 12 months into the filter placement or 1 month post-removal, whichever came first. And they defined safety as either no serious adverse events in the operative period or no significant perforations, embolizations, occlusions, whatever those complications may be, 12 months into the filter placement. And they had a pretty high threshold set for their hypotheses. So for the safety outcome, they predicted that more than 80% of people would meet it. And for the effectiveness outcome, the threshold was even higher at 90%. All right, so to start off with, right, we can start with the demographics here. You can look at the average age, it's about 62 and pretty evenly split between male and female, right? 53% male, 46% female. And what we wanted to point out is that these filters were placed in patients who were pretty sick. They had few therapeutic alternatives, which is why it came to this point. And some of the major comorbidities they had were malignancy, hypercoagulable disorders, stroke, and congestive heart failure. So at the time of presentation, most patients did have a VTE, VTE being venous thromboembolism. So about 71.3% had an acute or chronic VTE. 31% of those were pulmonary embolisms, 60% were DVT, and 34% had a history of a venous thromboembolism. Ultimately, what it came down to was only 9% of patients neither had a current VTE or a history of it. So most people in this study did have some kind of VT history in their past. And going a little bit into the specifics here, the IVC filter that they used, as Austin mentioned, depending on where you place it, there are different types. Most of them were infrarenal, which is usually the preferred spot, 1,386. Most of them were retrievable as well, which is also preferable. So that was at 90.2%. And what's interesting is the reason that the filters were placed for these patients. So similar to the algorithm we talked about earlier, most of the filters were placed because the anticoagulation was either contraindicated or failed, and only 126 people had the filter placed as prophylaxis, which you can see at the very bottom of the table there. All right, so this table is kind of the crux of the study. So here's where we can see if it really met its outcomes, right? So the first row over there, the primary safety event rate at 12 months, the rate is 89.4%. And even if I take the lower confidence interval, 85.3, that still crosses their expected 80% threshold for safety. So it met the safety outcome. And then if you look at the effectiveness outcome, which is on the bottom of the table here, that was 96.4, with their lower confidence interval being 94.9, which still crosses their 90% threshold. So both safety and effectiveness outcomes were achieved. But more so, what we thought was interesting was their adverse event rate. So procedural adverse events were uncommon and usually minor. And excluding strut perforation, which was a more common complication that we'll talk about, VCF-related adverse events were pretty rare. It was about 0.5% of people who had adverse events from the filter. The perforation was seen in 31 of 201 patients whose CT scans they looked at from the study, but only 3 of them were truly clinically significant. So here too, the complication rate was very low. And this kind of branches off from the previous slide, where now we're looking specifically at how many patients post-filter had a thromboembolism. So post-filter, thromboembolism occurred only in 6.5% of the patients. None of them were fatal. And of these, 5.2% had DVTs, 1.6 had PEs, and 1.1 had some kind of caval thrombotic occlusion. If you look at patients who only had filters placed prophylactically, none of them had PEs, 5 of them had DVTs, and 1 had a caval thrombotic event. So this preliminarily demonstrates that the rate of VTE development in patients who had filter placements, whether it was prophylactic or not, was pretty low. And the Kaplan-Meier curves on the top here go to support the data that I cited. As you can see, the freedom from pulmonary embolism, even at the 12-month time point, which is all the graphs go up until for now, are still pretty high. All right, and finally, the study also followed patients who had their filter removed up until 1 month. And of the 647 patients who presented for filter retrieval, it was only successful in, well, it was successful in 632 of 640 of them, which is 98.8%. So that was at a mean of 101 days and a median of 86 days following placement. But it is interesting that of all the people who they attempted retrieval for, 98.8% of them had it successfully retrieved. So what this kind of tells us is in the structure of this study, they had a plan for these patients, they followed up with them regularly, and that's possibly what could have contributed to that high retrieval rate. Oftentimes, that's an issue that clinicians face, being able to not only put in the filters, but have them removed in a timely fashion, and perhaps making a plan and following up more clinically as well could improve retrieval rates and low adverse event rates for patients outside of this study as well. And finally, one last thing they did was they selected parameters, various parameters from these patients' backgrounds, whether it was what their indication for filter placement was or how long they had the filter placed. And they tried to see if any of these factors were significantly correlated to the occurrence of adverse events. So as you can see here, the only factor that they could link to adverse event occurrence that was significant was a hypercoagulable disorder. All right, so we talked a lot about the results, but as with every study, it's important that we take it with a grain of salt. So first of all, this study was unrandomized with no control group. That in and of itself is something that prevents you from establishing causality. It's something which shows us that while this study demonstrated that these filters had low adverse events, it's more so something that can help instill confidence in the filters, but doesn't say that these filters are without a doubt safe to use or effective. the reason they did that is because ethically, it wouldn't be right to not put filters in for patients for whom it was indicated. So it gets a little tricky when you're trying to design a study with such a patient group. Continuing along these ethical lines, it's also why anticoagulation therapy couldn't simply be discontinued for a certain group. And so it's unsure how much of the contribution to VTE prevention was from anticoagulation versus from the filter placement. The constraint that Austin and I found most significant was the decline in number of patients that could be evaluated over time. So with any large RCT, you tend to have patient withdrawal, you tend to have patients are lost to follow-up, or the filters are removed, and so on. So while we started with 1,421 patients, when we looked at the safety endpoint, only 293 patients were included in that statistical calculation. And for the effectiveness endpoint, the sample size was 829. So both of these numbers, while it's better for the effectiveness, they're both nowhere close to the original sample size. And that's just something to keep in mind. Going off of that, the next point as well is that almost half the filters were removed prior to 1 year. So that's what's contributing to these low sample sizes. But even once removed, they were only followed for a month. And finally, the last issue that we found was when patients were evaluated at presentation, like we mentioned, most patients had a VTE present. But the study did admit that this evaluation was not entirely complete, and oftentimes this is because of funding issues. And what this means is that, say, a week into the study, if someone had a PE or DVT, you can't say with absolute certainty that it wasn't a new one or whether the patient came in with it. So what are the big takeaways? First off, for most patients who had filters placed, anticoagulation therapy was contraindicated or had failed. So that was the number one indication for filter placement. In terms of the number of adverse events that happened, it was an incidence of about 6.5%. That's pretty comparable to other studies as well. Both the safety and the effectiveness goals were met. Complications were rare. And planning for removal at the time of insertion and regular follow-up could have been what was responsible for that high retrieval rate that we talked about. So that's something clinicians could take away from this as they plan for filter placements in their patients too. Finally, while the study didn't directly support this conclusion, it's good to keep in mind that patients should be reevaluated following filter placement for appropriateness of anticoagulation therapy, and the filter should be removed as soon as it's possible to do so when the risk for PE is either no longer elevated or anticoagulation is sufficient. So to end with, if I could kind of distill this whole trial down in one sentence, I'm going to cheat and do it in three. So in a population with a very high prevalence of current VTE and comorbid conditions of filter placement, there were very few DVTs and fewer PEs, and none of them were fatal. There were relatively fewer DVTs and no PEs for the prophylactic population. So this documents the lower frequency of adverse events and increased our confidence in IVC filters. We kind of strayed away from going with the paper's original conclusion that filters are safe and effective, because without a lack of control group and a small sample size, we don't think that would be entirely right to say. But we can certainly say with confidence that there's a lower frequency of adverse events associated with these filters and still every reason to use them clinically. Great, thank you. Does anyone have any questions? We're happy to take them.
That was a lovely presentation, both of you. Thank you very much. I see Anthony, you have your hand up. Feel free to unmute and ask your question.
Yeah, I just had a quick question. It sounds like with the vena cava filters, there isn't many. It sounds like there are still a lot of studies going on and trying to figure out their safety and efficacy. Are you aware of any randomized RCT tests or papers comparing vena cava filters to using anticoagulants? Like essentially somebody has a pulmonary embolism and then is immediately placed on a vena cava filter without starting with coagulation, or regardless of whether they have a contraindication.
That's a great question. I personally am not aware, but we have Dr. Vedantham here with us today, and I'm sure he has a great answer for you.
Sure. Yeah. So first of all, hi everyone, and really terrific presentations by both of you. So very nicely done. In terms of the question of randomized trials, there have been a few, and they're alluded to. I think someone briefly mentioned in the chat as well. The original trial was done in the 1990s. It was called the PREPIC trial. It was done in France, and basically it took people who they had DVT and they were all, or PE, and they were anticoagulation candidates, and randomize them to either receive or not receive an additional IVC filter placed on top of their anticoagulation. The patients were followed, and the study wasn't perfectly powered to really answer its question, but it did enroll 400 patients, and in that study, there were less PEs in the people who got filters if you followed them long enough, or over like an 8-year period. There were, however, more counted DVT events. The overall rate of venous thromboembolic events was the same in both treatment arms. And so the conclusions around that were kind of indeterminate. There was then a PREPIC 2 study that was performed more recently and published probably around 6 or 7 years ago. And in that study, they took people with pulmonary embolism and higher risk features, people that are more likely to get worse, essentially, and randomized them to receive or not receive a retrievable IVC filter, and then to have it removed within a few months, and followed them. And in that study, filters did not, and again, this was anticoagulation candidates, remember that, right? So people in both arms got anticoagulated. In that study, again, filters did not demonstrate any benefit in terms of preventing additional PE events, And so, there's very limited data out there. They're not well-powered studies, but what's there, the benefit of adding a filter onto anticoagulation is highly questionable. Really, filters are best suited for people that can't get anticoagulated, for the most part,
Thank you.
Sure.
Great, thank you so much. There was another question that Austin and I kind of thought would be helpful to hear from you for our audience as well. So we were wondering if, based on this trial, if you would change anything in your clinical practice, or what your biggest takeaway was from it that you might use in your clinic when you see patients.
Yeah, so I think that, you have to sort of separate two different types of outcomes. One is outcomes related to kind of the disease, like, for example, pulmonary embolism events, right? I think for that, you pointed out the substantial losses to follow-up. And we know that PE, people, one of the presentations of PE is just sudden death, right, out in the world, right? And so the challenge is, if you don't follow all the patients, it's very hard to know that you did not miss PE cases. And so, it's likely that the incidence of PE in the study was underestimated, and it's hard to know, therefore, if the filters were effective in that sense. But the other side of it is that the reason the study was really done was that the types of events that were occurring were filter fractures, penetrations, migrations, and embolizations. So they were mechanical events with the filters. And I think the study is pretty powerful in the sense that, a substantial number of patients were followed prospectively, and they had imaging tests, and that was examined very carefully in a very structured, way by a core lab and all that, right? And demonstrated a very low, adverse event rate in terms of those kinds of events, which suggests that, at least for the 4 filter brands that, that fulfill their enrollment totals in this study, that overall the rate of events, that type of event, is very low. And I think that's very important, for our clinical practice, because, many of us, like myself included, we're pretty concerned about putting these devices in, not knowing if one day you're going to be trying to retrieve them out of the heart or something like that, right? I think that there is more confidence in using them for that reason, I think.
Awesome. We have a question in the chat, Dr. Vedantham. Thoughts on the International Cooperative PE Registry and IVC filters used in it?
The ICOPR registry. Yes. So the ICOPR registry was a large 2,000 plus patient international registry that followed patients with VTE, and that it had, I think they had filters placed. I recall there was a publication that looked at the subset of patients with massive PE. And in those patients, there seemed to be a suggestion that the rate of PE in patients who received filters was less than the rate of the rate of death in patients who had received filters was less than the rate of death in patients who did not. Now, again, registry data is very hard because remember, you're not really comparing comparable cohorts, right? And people make clinical decisions based not just on objective features of the disease, but just on subjective features, right? I mean, you make a judgment and say, well, I'm worried about this patient. They may be more prone to have a fatal PE. I'd like to place that filter, right? And there's some subjectivity there too, right? And when you go and do a comparison within a context of a registry, you don't have the ability to fully control for that, right? So you have to be a little bit careful in interpreting that. But there was a suggestion that the people with massive PE, in other words, they were hypotensive or intubated or whatever, with their PE, that there may have been a benefit in those patients,
Awesome, thank you. Another question is, how do we improve following these patients to get filters removed when it's no longer needed?
That's a great point. And, it's something that there have been a number of strategies that have been tried, and some of them have been published and all that. Some sites have gone to the step of a filter clinic where basically everybody that gets a filter is asked to come back for a clinic visit. Other sites have a coordinator, put someone on a tracking list, and then have a study coordinator reach out to the patient's physician, every month after filter placement. The challenge with this is that the person that places the filter needs to take charge of it, because the other physicians tend to forget that the filter's there, right? So the person that placed it really ought to take a substantial role, but that's not something that all IRs have always been doing, over the years, right? But that's a very important thing. And then there needs to be kind of infrastructure, right? It's hard for a physician to go make those phone calls, right? And remember, it's not a one-time thing because some people are ready to have their filter out in a week. Other people, just say someone had the filter placed after brain surgery, right? Well, they can't get anticoagulation for the first 7 weeks, let's say, right? At some point, the team decides, okay, well, I think we're comfortable anticoagulating that patient now, right? And then at that point, it becomes reasonable to take the filter out, right? But again, that requires multiple sequential follow-up to identify at that time point, right? And get the filter out. So it does take some resourcing, right? To be able to do that, but it is very important to do. And I think as the general principle of placing any permanent device in a patient, that's just something that we have to be open to doing. It should really be part and parcel of putting a device in.
Yeah, I think that's really important advice. How do you determine when it's a good time to remove them, or how do you know when it's no longer needed?
Yeah, that's a great question. A lot of it comes down to you're kind of estimating the risk of a PE, right? And that's not, it's very much some parts of that risk can be kind of quantified and some parts can't, But the bottom line is that first and foremost, in someone that has had a DVT or a PE episode, if it's in the first few months, really they need to be able to be anticoagulated, right? Safely, that's a big thing. In someone that never had a DVT, you really want to get that thing out as soon as the risk of a PE goes down. So for example, somebody had it placed prior to surgery, and just to be clear, this is not, a lot of these get done, but how many of them are truly indicated is highly questionable, probably less than actually get done, But the bottom line is that once that patient is up and moving around, the risk of a PE, depending on what kind of surgery they had, goes down precipitously, right? So it's probably better to get them out earlier rather than later, and just to prevent, the chance of any adverse event or the chance that the filter grows into the cable wall and just can't get removed, Nowadays, we've gotten pretty good at getting them out. But having said that, sometimes they can be very tough to get out after more than a few months.
Okay, I have another question in the chat. Can you discuss how we as trainees can get more involved in RCTs such as ATTRACT, C-TRACT, or PE-TRACT?
Sure, of course, that's a topic that's near and dear to my heart, of course. I think that there are, the first thing as an IR in general is to become clinically credible, right? And make connections with other physicians. And as part of that, there's one of the big assets in doing that is scholarship, actually, because when we're talking about DVT, we talk about it in a certain way using certain terms. Believe it or not, if you sit down with the 3 hematologists and hear them talk, it's like you're talking a different language altogether. They're not even talking, they don't think the way we think and vice versa. They're thinking about thrombosis as a field condition. It's how prothrombotic your body is. Whereas we think about it more from anatomical terms, right? Sometimes physiological terms, they don't think that way at all, really. So the first thing to realize is that when you read the medical literature, it just reads very differently, right? But if you want to do randomized trials and you want to do high quality research, you need multidisciplinary collaboration. And therefore, you need to be able to kind of earn your way into their trust. And one of the best ways there is to learn to talk the language that they talk to some extent, right? And then you have to be willing to take an investigator posture and train yourself to talk in terms of if something works. I'm doing a study to ask the question of whether something works, as opposed to I'm doing a study to show that something works, right? Because at the end of the day, what matters is are patients getting the best care? It doesn't matter, we're not there to push procedures, really. We're there to do things that make sure patients are getting the best care. And if that means not doing a procedure, that's absolutely fine, right? But we do want to play a leadership role in being the ones to carefully assess that and do the research, because we know more about our procedures than other people do. And there's a lot of considerations that need to go into the research, right? And then I think finding, research training, don't assume that because you're a physician, you're trained as a physician, that you're trained as a researcher, because it's by no means the case, both in terms of the design of studies and in terms of the real world implementation of studies. Those are each different beasts altogether. And unfortunately, we just, we generally don't get really well trained in those items. And so it's very important to also try and learn about that stuff as well and treat it as a separate domain of learning.
I think it's really important, like you said. I like how you mentioned that we're asking questions to see if something works, not trying to prove that something works or push something. So it's really nice. Are there any more questions? Oh, sorry, go ahead.
No, I was going to say it's challenging sometimes because, investigators, you choose to study something because you have a hypothesis, right? You wouldn't be doing and putting all your time into it if you didn't believe somewhere deep down that it might actually help somebody, right? So I think it really takes a kind of discipline, right, to recognize that everybody has subconscious bias that they apply. And that's just part of being a human, really. And but as an investigator, your job is to try and acknowledge that and do your best to stamp it out and work with other colleagues to balance things out, right? So that you go and evaluate and ask questions in a very balanced and fair way.
Absolutely.
I have a question about the methods used in this study. So since there's no control group, they decided to do an exact binomial test. And the hypothesis percentage they used were 80%, 90% respectively for safety and efficacy. I was wondering, how did they get these numbers to compare with their previous similar trials, maybe for patients who does not have contraindication for anticoagulation and has no control group, and these are the numbers they choose to evaluate the efficacy of those anticoagulation therapy. And there's just no information on why they chose these particular numbers, 80 and 90%.
Yeah, those are.
Sorry.
I'll just frame it, then maybe you can continue. But so when you approach the FDA to do something, and this is true usually usually it's a company, right, that approaches the FDA. I have a new device and I want to run a trial and I want to get it on the market, right? And so the FDA interacts with research teams, whether it's from industry or sometimes from academia, right? And what the FDA will ask you when you start is, okay, well, what are you intending to do? Are you intending to get this device on the market, keep it on the market in the case of filters? What's the goal here, right? And then it will ask you to present to them, well, show us the literature and explain to us what's the reasonable expectation, right, in this disease state, in this population, for this particular, for standard care. And then also, what are you saying would be a likely difference with your treatment or whatever? And it establishes, you negotiate with them what's called a performance threshold, you know, usually defined in kind of binary terms, actually, right? Like here. And so obviously they went to the literature, and but the thing is, it's so influenced by the manufacturer or the sponsor of the study from presenting whatever literature they want to present to the FDA. And typically, you know, they're trying to make it as lax as possible to get the easiest approach to approval, right? With a study like this, with the manufacturers kind of behind it, but being approached by the societies, you know, it probably wouldn't have been quite as aggressive as a company. But overall, probably the thinking was that we want to kind of set a very, very fair bar to make sure that essentially the FDA doesn't withdraw these devices from the market unless there's a good reason to do so, right? Efficacy is very hard here because you don't have a control group. It's all, I mean, it's just very hard to attribute anything to the filters as opposed to anticoagulation, right? But you can just try and come up with what's in the literature and then define a confidence interval around that and say, well, we'd like to have 90% power to demonstrate that we're not inferior to whatever is going on that we've demonstrated from the literature or something like that. That's the process. Why they chose these numbers, I don't.
Thank you. I was wondering if there was just like a historical, if this is something that's usually used, this number, when you have this kind of trials. Thank you.
Not for performance thresholds, right? Now, when it comes to statistical power, that's a different parameter, right? When it comes to statistical power, generally speaking, you know, if you want to get something like a device or a drug on the market, it's pretty stringent. You know, they expect both a very well-controlled study as well as statistical power that's 90% plus. Now, if you're doing, on the other hand, another kind of study, like more of a health outcome study, and it's not designed to change the label of a drug or a device, then the FDA is open to being a bit more lax, you know, in terms of what standard is used, and 80% power might be viewed as okay in that kind of situation. But, you know, it also varies based on the risk level of the product in the perception of the FDA. It's a very risky product. They don't want to let that on the market unless they're absolutely sure it really has a benefit and that it's safe. But if it's something that's lower risk, they tend to be more flexible.
Okay, our next question is, now with DOAC and low-dose DOAC trials, Amplify, Extend, and Einstein Choice, do you think these will be prescribed in a prolonged fashion more frequently in high-risk patients?
Yes, and they already are, actually. Yeah, I based on those studies, it's pretty common to switch people to low-dose extended therapy. People in particular with unprovoked DVT. You know, generally people that have had DVT in the context of a major provocation, meaning major surgery, major trauma with a bony fracture, pregnancy. Those are major provocations. And so those provocations could make someone clot, even if they only have a minor inherent problem with their clotting system. And so studies have shown that people with a provoked DVT, after you give them anticoagulation for 3 months and stop it, they have a very low rate of recurrence. On the other hand, people with an unprovoked DVT, again, someone was just going about their daily business in the world and all of a sudden they developed a DVT, that indicates a very major problem with the clotting system, right? So those people, clinical trials have demonstrated very clearly that they have a much higher rate of recurrence after you stop anticoagulation. And so there's been a lot of hunger in figuring out, you know, before there have been studies demonstrating that a longer anticoagulation duration is better for those patients. And so the recommendations were kind of indefinite therapy, but indefinite therapy has risks, obviously, and people don't really want to do it either, right? And so there were additional trials of these lower dose kinds of regimens, and they actually were pretty remarkable in their success and their ability to reduce recurrent VTE events with minimal effect on bleeding risk, you know? And so they actually are a very good way to go for people that still have some risk of a VTE down the road.
So in this study, Ashna alluded to that there are many different types of IVC filters, like there's retrievable ones and like convertible ones. I was wondering from your experience, which ones are like, are there any studies that kind of pit, you know, one type against another, and like which is like the most commonly used?
There's only been, I think it was one study done at the University of Michigan that kind of compared the greenfield filter against other filters. It wasn't really a direct, like well-powered randomized trial or anything like that, you know. And it suggested, as you might expect, that the greenfield filter performed pretty well. But having said that, in terms of really high quality comparative studies, no. And you know, one of the challenges is one, no company will fund that study, you know. They don't really want to put their device up, you know. And then secondly, the hardest thing is that, you know, you're trying to demonstrate a difference. You just need such a large number of patients to demonstrate a difference with these things that it's a pretty large, complex, long, and expensive study to do it. And these, you know, devices are very different than drugs. You can get devices on the market via a pathway, you know, a 510K type pathway. And once they're on the market, the incentive to do trials within industry, it plummets. It's one of the big problems we have in our field, right? Is that once a device gets on the market, there's no incentive for the company to want to subject it to a fair test, right? And so it really then is incumbent on investigators to really lead those studies and get them funded from public sources or foundations or whatever. And that's challenging. It takes a lot of work to do that sort of thing, you know. But we definitely need more of those kinds of studies. But there isn't any head-to-head kind of filter versus filter type trial out there, except the one I mentioned to my knowledge. I should mention that the newest device is kind of the convertible, and then there's also other devices that are coming out that are even more sort of, you know, they vaporize in the body kind of thing, you know, even more innovative in that sense. I think because they're so different, I think you might start to see some trials, you know, of those kinds of devices, because they have particular parameters that might make them, they might have a specific type of outcome, for example, that could be statistically tested and that would clearly benefit the newer device, you know. So the companies might be motivated in doing that kind of thing, but we'll see, you know.
Great
There
question,
it is.
everybody. Any other questions from the audience or any other comments from Dr. Vedantham? If not,
Really
sorry, go ahead.
great. It's just, you know, really just great to have so many people on, you know, and you know, interested in these topics, and I hope that you'll, you know, continue to engage in this kind of way, because we need people, you know, people talking, and then also just thinking about how to ask these questions, and you know, hopefully we'll have a whole new generation of IR researchers going forward.
Yeah, absolutely thrilled to see so many people here. And then just before we wrap up, I want to send the membership form in the chat again for anyone who missed it earlier. But if you're a new member and you want to participate in further journal clubs, please fill out this form. And thank you again, everyone, for being here. And we'll post this recording on our YouTube channel shortly, too. So, all right.
Thanks.
Take care. Great job.
Thank you, Ashna and Austin. That was amazing.
For hosting.
Thank you.
Here.